All right, good morning, everyone. I am so delighted to be able to introduce my friend and colleague, Dr. Dara Mendez. Dr. Mendez is an associate professor with tenure of epidemiology at the University of Pittsburgh School of Public Health, specializing in reproductive justice, maternal and child health, and health equity. She earned her MPH and PhD in maternal and child health epidemiology with a certificate in health equity from the University of North Carolina, Chapel Hill, before returning to Pittsburgh, which is her hometown, as faculty. Her work focuses on the intersections of various forms of oppression, stress, and geographic location to understanding Black maternal and infant health, women's health, and racial and ethnic health disparities. She leads several federally funded projects focused on supporting the health and thriving of perinatal people, including the serving as one of the PIs of the Embrace Center, which is a community-led initiative combining research, policy, education, and advocacy to advance maternal and reproductive health equity and justice with a focus on Black birthing people in Allegheny County. She also has several leadership roles. If I name them all, it would take the whole hour. So I'll just say she serves on the Board of Health for Allegheny County and on the executive team of the Black Equity Coalition. And she's won multiple local and national awards for her work, including she will be getting the Heroine Award from the YWCA of Greater Pittsburgh tomorrow. And really, like, she does some of the most innovative, transformative, community-driven work I've seen, and I'm just so delighted that she'll be able to share her work with us today. Thank you so much. Welcome. Thank you.
Good morning. Thank you, Maya, for that introduction. I feel like I have a tall order now after today, but good morning. Good to see you all. I was joking with them a little earlier that I think in my previous lifetime, I was a pediatrician. I really have so much respect for pediatricians. I see you all as the heroes of medicine, and your leadership. I continue to really marvel at and feel excited to just be in front of you all today. So my talk today is about maternal and reproductive health equity, justice, and joy. But before I start, I wanted to uplift and acknowledge those who we call the mothers of gynecology. So sometimes I like to acknowledge them and bring them into this space. So this picture in the background, has anyone ever seen this picture or familiar with it? So it's based in Montgomery, Alabama, and it's an artistic creation developed by Michelle Browder. And this is of Anarcha, Lucy, and Betsy. And they were enslaved women around Montgomery, Alabama. And with neither consent nor anesthesia, they were experimented upon by Dr. Marion J. Sims, who at one point was considered the father of gynecology. And this was in the 1840s. After publishing the results of his success, he moved to New York to seek fame and fortune. And this 15-foot monument really honors those three women and many other women. A lot of the practices that we know today in obstetrics and gynecology are based on that work. And their story continues on. And so this space here honors them and their legacy and what we know today in medicine. All right. Okay, so over the past 20 or more years, I've had the opportunity to work in concert with leaders, community members, scholars, and students to understand and promote health equity, specifically in reproductive health and birth. And so I wanted to upfront acknowledge many of them. Some of you in this room and on the online with us work with a number of these organizations and either co-lead work with these organizations. And so wanted to just acknowledge incredible individuals who really set the foundation for the work that I'm going to share today. So the talk that I'm giving today is really focused on my research program on identifying and implementing strategies related to structural and social contexts and how that creates inequitable health outcomes, particularly in the area of pregnancy, birth, and women's health. So I wanted to start with really brief background and some praxis and foundations, and then give two exemplars of that work. One is the Streamer study, which I'll describe. It's focused on policy interventions. And then the Embrace Maternal Health Research Center of Excellence, which is one of 12 research centers in the country. All right. So I wanted to start with reproductive justice. And I know typically in audiences that are focused on reproductive health, reproductive justice is a pretty known framework and tenet. But I wanted to start here because I believe that reproductive justice is foundational for the work that we do, not just in the research that we do, but I would also say for the field of pediatrics as well. And so the RJ framework was actually developed by Black women in the mid-1990s. And it was at a time when there was leadership in the areas of the women's movement and reproductive rights movements, which really centered the experiences of white women and middle-class women and excluded the experiences of Black women in particular. And at the time, part of the conversation was around uplifting access to abortion care, which is really important. But many Black women and women of color were saying, abortion is important. We're experiencing sterilization. We're experiencing harms to our reproductive health in general. And so they developed this framework as a way for us to not only articulate the experiences in reproductive health, but across the life course. And so it is a human rights framework to maintain bodily autonomy and to have children, not have children, parent the children we have in safe and sustainable communities, and have sexual expression not tied to reproduction. And so I would say when we think about the field of pediatrics specifically, many of you are probably engaged in the work in the first bullet, as well as the third bullet. But I would also say many of you work with people across the lifespan, right? And so the reproductive health across the lifespan is important. And so I use this as a framing for a lot of my work. But joy is also a praxis. Reproductive joy is an affirmation of the positive aspects of reproductive experiences. And so many of us who are doing work in health disparities and health equity, there's a tendency, obviously, to focus on adverse outcomes, right? But we know that joy and positive outcomes are really important for us to center in our work. So the embrace of Black life reflects the Black feminist praxis of understanding joy and pleasure as forms of resistance, self-care, and power. And Imani Perry shares that Blackness is an immense and defiant joy. She asserts that exhilaration in Black life is not to mute or minimize racism, but to shame racism, to damn it to hell. Do not misunderstand. This joy is not an absence of grief or rage or distraction. It is insistence. And then I also wanted to just briefly uplift who I consider, in addition to Anarka, Betsy, and Lucy, the foremothers of a lot of the work that we do today. And for those who are familiar, this division, as it exists today, most people who are in leadership in the CDC Division of Reproductive Health have been eliminated or rifed. And so there are tremendous implications of our work in this space in general. But I consider this the Magnificent Seven. They were some of the first people at the Centers for Disease Control and Prevention to say the disparities that we see in infant mortality and preterm birth, for example, are not a result of something that's innate or something that's wrong with Black women or Black populations or communities, but what is their lived experience? And so they really turned that question on its head. And at a time in the 90s at the CDC, that was unheard of. Their picture was actually taken by Dr. Bill Jenkins. And if you're not familiar, he was one of the epidemiologists who blew the whistle on the Tuskegee syphilis experiment. And his partner is Dr. Diane Rowley, who's in this picture. Many of them actually mentored me through my career. And I just briefly show this study in particular because this was one of the first studies that many of those individuals in that picture conducted to really question this notion that disparities that we see in infant mortality cannot necessarily be explained by individual characteristics. It cannot also be explained only by education or income. And what they showed is that these disparities still exist, particularly in infant death, and that the racial differences were attributable to excess low birth weight among Black infants. And this was really taking into account college education, college-educated women, and what are the differences. We know even in contemporary data today that those racial disparities exist, not only in infant mortality, preterm birth outcomes, but also many maternal health outcomes. So over the past several decades, there's been a growing body of research, practice, and community work related to reproductive health equity. And this graphic just attempts to show a few core areas of my work. So one is looking at racial discrimination or racism and other forms of discrimination and its effects on health. structural and community interventions, as well as place and geography, and in many ways, how these three intersect. So for the purposes of today, I will present on the Streamer study, a policy-focused study, and then Embrace. I know there's been a couple of questions or folks who've reached out about some of the other studies. So during the Q&A, I can absolutely share those. I wanted to also shout out my collaboration with Dr. Maya Raghavan on the Thrive study, which is focused on community interventions, and that study just kicked off as well. And so the Streamer study, which is the research study of racial equity among Medicaid recipients, is in its fourth year. And this study in particular is focused on understanding policy level interventions in Medicaid and its implications for maternal and infant health. This study is a collaboration funded by the Robert Wood Johnson Foundation and NIH, and it includes collaborators from Healthy Start, the Maternity Care Coalition, Hamilton Health Center, March of Dimes, PA Doula Commission, and also the Department of Human Services. So this is a coalition of partners across the state of Pennsylvania. And Streamer is a mixed methods research study designed to evaluate the implementation and early effects of two specific Medicaid payment policy interventions in Pennsylvania, and really focused on racial equity, and I'll describe those in a little bit, as well as a third policy, which is focused on reimbursement for doula care. So I'm sure many of you are probably more familiar with the third, probably less familiar with the payment reform policies that are happening in the back end. So the overall goal of this study, once again, is to understand these specific Medicaid policies. We're estimating the effects of healthcare quality interventions through payment models, doula care as well, and then also assessing beneficiaries, clinicians, MCO leaders, doulas, and their experiences. So it is a mixed method study in which we're using Medicaid claims data, quantitative data, coupled with the experiences of individuals across the state of Pennsylvania. And so I just wanted to share really briefly about some of the qualitative work that we're doing, and then have a little bit of an ask in a minute. And then I also will share a bit about our quantitative work that we're leading. And so we have this, as I mentioned, this is our fourth year of the study. And so when we first started, we wanted to have an understanding of, okay, these policies are in place, which I'll describe a little bit in a minute. But how are managed care organizations sort of reacting? How are they implementing it, right? It's one thing to have a policy in place. It's another to really sort of interrogate what that looks like in practice. And so we conducted interviews with MCO leaders across the state. We do have a published paper. If you, I'll show you our website at the end, where if you'd like to read a little bit more. And these were MCOs across the state, really trying to understand how are they thinking about racial equity, and how are they particularly engaging with payment reform and payment policies to improve outcomes in the state, and specifically for Black populations. We've also conducted interviews with doulas, and we're in the process of analyzing that data, and that manuscript actually is under review. And then we've also interviewed and conducted focus groups with birthing people and parents across the state of Pennsylvania, many of which are in Medicaid. And this is actually one of the first studies that really is leading qualitative work around the lived experiences of people in Medicaid. And then also clinicians and healthcare workers, which is where you all come in, and I'll share a little bit more. Our quantitative study, as I mentioned, is using Medicaid claims data to really answer a few questions. And one is focused on the implications for well-child visits. I'm going to focus on that today for this audience in particular, and then also the effects on maternal health. And in our overall study, we're really interested in the payment reform policies in the state of Pennsylvania, how that compares over time, and what that looks like in comparison to many other states in the US. And so this particular the particular policies that I'll describe a little bit further are the only ones that exist in Medicaid policy, or Pennsylvania, sorry, is the only state in the United States that actually has payment reform focused on improving outcomes for Black populations. And what it's focused on is a payment equity, pay for performance approach. In general, a pay-for-performance approach, as you are probably familiar, and Medicaid means that as outcomes improve, there are additional incentives and financial incentives that would go to the MCO and also to those particular health plans and to some degree, the clinicians who may be leading that work. Pennsylvania in particular has set the equity incentive payment reform that says if there are increases and improvements in specific outcomes, well, child visits, as well as initiation of prenatal care for Black populations in the state, in particular, that there's an additional incentive on top. And so when we think about equity and our sort of focus on how to achieve equity, there are a number of arguments for what is a moral human rights argument for addressing equity? What are the ways in which we think about how we carry out our practice? What is the business model for equity? In this particular case, they're using that financial incentive and financial argument for incentivizing. So this is just without getting into all of the details of this graphic, really the main point here is that the equity incentive payment program, which was initiated in 2020, and so there was early work in 2019, initiated in 2020, and it provides financial incentives, as I mentioned, for MCOs on improvements in initiation and prenatal care and well-child visits for Black populations. And it's an increase of up to 0.15% of the total annual MCO payments. And that's based on increase and decrease. There are ways in which they're implementing this now. And one question that I've asked recently is, well, what does this look like across the state? What are the implications for health plans? How are they thinking about that? And much of this information is private, so we don't necessarily know what all of the outcomes may look like. We don't necessarily know what the final incentive payment has looked like for the health plans as well across the state. And so for our analysis on the equity incentive and well-child visits in particular, we looked at Medicaid claims between 2018 and 2020 for individuals assigned as female between the ages of 15 and 50 who delivered a baby within that same time frame in Pennsylvania. And so pre-policy, as I mentioned, this policy went into effect in 2020, right? January 2020, before we went into a full sort of shift, right, due to the pandemic. So you can imagine, this policy, although there is the impetus for its implementation, that was completely disrupted in 2020, even though there were plans for that. And then we also looked at post-policy, which was January 2020 to 2021. In our analyses, we also considered the effects of COVID, state level variables, and other things that may have impacted the outcomes. And we were particularly looking at the time trend and receipt of recommended number of well-child visits of 6 or greater. And that is the actual HEDIS metric that is being used by the state to determine whether or not these outcomes are reached and what are ways in which the MCOs may be receiving an incentive as a result. And so we analyzed this before and after the health equity incentive program in which it took effect, comparing trends for Black children to children of other racial groups. And then our final analysis included a little over 100,000 birthing parent-child dyads in the state of Pennsylvania. Okay, so this here shows our key results. We actually have a paper that we submitted of this analysis, so open to feedback, questions that may help us to kind of think about this work and continue to develop this work. But among Black children, what we found were that trends in receipt of the recommended, once again, 6 or more child visits within 15 months of age declined from pre-intervention to early post-intervention, but this could be potentially the likely effects of COVID. The rates do appear to rebound by the end of the follow-up period when compared to the pre-intervention levels. And our models estimated that among Black children, the rates of well-child visit utilization was not statistically changed at post-intervention. So although there's a slight dip, this rebounded. And you can see, so on the left, this is including the actual versus predicted model for Black individuals, and then on the right for non-Black individuals. When you compare the rates in general, there are, as you see, existing disparities. So we're talking about a 60% compared to close to 70, 66 to 70%. Among non-Black children, which is the comparison group, the trend was somewhat different, with rates of well-child visits among those turning 15 months of age declining post-COVID and then not rebounding to pre-trend levels. And so we estimated a 6% decline in well-child visit utilization, right? And so although covariates did not predict well-child visit rates, we found that the vaccine availability actually during the time, and we were able to measure that based on county level estimates, increased well-child visit rates among Black children by 8%. There was also some regional heterogeneity, so there are MCO regions across the state of Pennsylvania as well. And so what we found is that among Black children, rates of well-child visits appeared to increase more post-intervention in the Southwest region. So that's our region, actually. And I'm sure many of you have a lot to do with that. While they appeared to worsen post-intervention in the Southeast region. And then in contrast, among non-Black children, we did not see a significant change by region. Okay, so then finally, I just wanted to share, this work is ongoing. We have been, as I mentioned, looking specifically at well-child visits, and it's changed because that is a core outcome for the Medicaid payment reform policy. We're also looking at outcomes among individuals as it relates to severe maternal morbidity and mortality. We are working closely with our colleagues to look at this within the PRAMS data, which is the Pregnancy Risk Assessment survey, and that survey is led by the Center for Disease Control and Prevention. We've been conducting analysis based on data up through 2022, have put out a Freedom of Information Act to obtain data through 2023. And as many of you may know, PRAMS data is no longer available on a national level. We've been working closely actually with our county to conduct our own local version of the Pregnancy Risk Assessment survey here. So this flyer, this information here is some of the qualitative work we're doing with the streamer study. So we're currently recruiting clinicians, including pediatricians and many others in this space, who provide care, to patients in the state of Pennsylvania. This is really trying to get a sense of how, we have these policies that are in place. How are they being implemented on multiple levels? And what does that look like even in your clinical practice? All right, so next I wanted to just share a little bit about the Embrace Center of Excellence. So the Embrace Center of Excellence is one of 12 maternal health research centers in the country. And we were funded through the Improve Network, which is a funded network through the National Institutes of Health, focused on racial equity and socioeconomic equity in severe maternal mortality and morbidity in the US. It is actually one of the first initiatives to do this work in the history of the United States, and these centers are the first in the history of the United States. So many of you may be familiar with Research Center of Excellence in Cancer, Research Center of Excellence even in health disparities. This is the first time that there's been an intentional focus on reproductive health, reproductive justice, and maternal health on a national level through research. And so I'm really thrilled that our team received funding to do this work. We are in year 2. We were set to begin this work with the notion that we are experiencing severe inequities in our region. There's thought leadership who've been conducting research in this area, but also community partners who've been leading work around maternal health and reproductive justice for quite some time. And so these disparities that we know exist are not happenstance, right? I say that these are human-made and manufactured and developed, that the things that we do on a policy level, on a structural level, on a community level, create the disparities that we see. When we think about and compare our outcomes in the United States compared to many other economically developed nations across the world, we fare in some of the worst ways, right? And so not only do we have implications for disparities here in the United States, right, for particular populations that have been excluded, whether that's Black populations and trans populations, but it has a detrimental effect on the entire population. And so the vision for Embrace is to achieve equitable maternal and reproductive health and well-being in Allegheny County and the surrounding region. and to advance maternal and reproductive health through multidisciplinary research, training, practice, and policy, really focused on the experiences of Black birthing people in Allegheny County. And the focus of our work is to ensure that those who are in thought leadership, those who are conducting this work, are really supported to move that forward and work in a collaborative, community-informed way. And one of the core elements of our work is the birth plan. So we see this as almost like a blueprint for our work. We use this in our grant application to say, hey, there's been over a decade of leaders really thinking about this. There's been research for decades as well, leading maternal and reproductive health, equity, and justice. And so this particular birth plan was developed with Healthy Start as the backbone organization, with over 50 organizations in the region, to say, okay, how do we come up with a plan? How do we come up with key elements that we think are important to move the work forward, to move the needle? And really the thought is, okay, as a practitioner, as a researcher, as a community leader, you can look at this plan and say, this is where I enter, right? These are the areas here that my organization, my research group, my clinical team connect with. This is the work that we lead, right? And so this is really a collective impact model. And the birth plan has 4 key areas, all of which are central to our work in Embrace, which is strengthening the workforce, strengthening systems of care, addressing social determinants of health, and then coordinating and streamlining MCH initiatives. And so some of the guiding frameworks for Embrace, I shared a little bit earlier: reproductive justice, as well as community engaged praxis. And the way that looks in practice for us is that each element of our center, each core of our center, is co-led by a community leader, also includes community partners and community health advocates as central collaborators in the area of practice and research. And then our work also centers public health critical race praxis, which is this notion that these disparities exist because of structural reasons, because of structural oppression, right? And it is connected to decision-making and power, right? So I say structural determinants are the power, the money, and the wealth, right? And decision-making. And then that leads to the social determinants: housing, transportation, food access, right? Those structures impact the social determinants. And so these are our overall aims: advancing interdisciplinary research, developing, implementing, and evaluating multi-level interventions, implementing training and education, as well as capacity building in a bidirectional capacity, and then also bidirectional collaborations with community initiatives and organizations. And this is some of the who, right? And so I have the pleasure of co-leading the Embrace Center with Dr. Maret Baru-Talabi, who is a rheumatologist who focuses on reproductive justice in the area of individuals experiencing chronic conditions such as lupus. And then many may also know Hai Simhan, who is director of maternal fetal medicine. We have a community component, and these are the leaders here. And many of you are familiar with Onome, who actually I think might be online or might be jet setting. As well as Jada Sherrill, who's the CEO of Healthy Start, Ashley Hill, who's former faculty here at Pitt, now at the University of Illinois in Chicago. I'm going to talk a little bit more about the ICC intervention, which is led by Dr. Stacy Bartlett and Cindy Salter. Stacy is a family medicine physician, and her training component is co-led by Dr. Kathy Haggerty and community leader Ngozi Tibbs, who leads Journey Lighter Coaching, one of, I would say, 2 IBCLCs in the region. Many of you actually may know her, have worked with her. And then our deputy director, Dr. Lovey, who makes sure that we're centered and well as we do this work. Also, our core staff, who are leading various components of the center. I want to make sure to uplift them, as well as our community health advocates, which is a program that is led by Healthy Start, one of our core partners. And community health advocates are really there to help us really center community experiences, really center the way in which we do the work. And they're integrated in various parts as co-partners and also team members across the center. And then I always say the teamwork makes the dream work, right? I know that's a little cliche, but it's really true for this center. And these are all the people involved. Many of the partners as well. Our Embrace Advisory Team, just wanted to mention that briefly, which includes leaders in medicine, leaders in policy, leaders in community space. And this graphic really just demonstrates all of the key elements of the Embrace Center of Excellence. As I mentioned, we have a training component, community component, research, core research project. We also have a data justice working group, a communications and dissemination working group. I'm going to share briefly about each component. And then, as I mentioned, we're one of 12 research centers in the country, and we are also connected to 2 hubs. And really the thought is this hub and spoke model is that each center leads their core work based on the needs of the region, but then also has a way to connect with the other centers across the country who are also leading in their own right, learning from one another through the 2 hubs. And one is the Implementation Science Hub, which is based out of UPenn, and then also a Data and Innovation Hub, which is based out of Johns Hopkins. I just show this graphic really to demonstrate that there are a number of ways in which we can think about multi-level interventions for centering Black birthing people as it relates to maternal health and reproductive health. And when we applied for the NIH U54 Center of Excellence grant, we proposed 3 core research studies or intervention-based research projects. And really the thought was that we, in order to move the needle, we need to be thinking about this from multiple levels, right? From the community level, healthcare systems level, or systems in general, but then also structural and policy, right? And so we applied for 3 projects. Unfortunately, only 1 project was selected when we finally received the funding from NIH. And so I'm going to focus a little bit on that healthcare systems level intervention that was specifically funded through this NIH fund. And that was through the really thought leadership of Dr. Stacy Bartlett and Cindy Salter. And this study is focused on developing a community-informed model of 4th trimester and interconceptional care. And we know currently in our current context that postpartum clinical care is really important. It's really critical. Many of you in pediatrics actually engage in postpartum care to some degree. And that the health of the birthing person in the postpartum period, in many cases between pregnancies, is also critical important. We know that the majority of maternal deaths and even experiences of maternal morbidity happen outside of the hospital and in the postpartum period, and sometimes up to 1 year postpartum. So your work that you all do in this field is really critical because you have touch points with individuals that are potentially experiencing the disparities that I discussed a little bit earlier. And so the model that I'll show a little bit, many of you may be familiar with, which is the implicit model that really speaks to that. We also know that there are huge disparities in who's receiving postpartum care, right? And so I mentioned in the Streamer study, which was focused on prenatal care, in particular, they're looking at initiation of prenatal care. And we know that there's so many other factors that relate to connection to care specifically, but we also know that disparities exist in postpartum care as well. Okay, so this research specifically addresses a critical need for strategies to deliver clinically and culturally relevant postpartum care to Black birthing people, as well as facilitate their access engagement with postpartum care. And so these are the core aims. So it's really evaluating clinical outcomes in the current model that I'll share in a minute, co-developing with our community partners, a community-informed postpartum care model, and then implementing that model in 5 Pittsburgh implicit sites. And one of the other components as well is a pilot universal or unconditional cash transfer that mirrors a 2-month paid family leave. And here are the team members. You may be familiar with one person in this room, Dr. Kristen Ray, who's one of our other collaborators for the ICC 4TM research study. And some of our other core partners include the Midwife Center, as well as the East Liberty Family Health Center. Okay, I'm just going to skip and just kind of move to the implicit model. So is anyone familiar with the implicit model in the room? No, okay. So this model actually has been in existence for quite some time. I actually found out and learned about this model as a postdoctoral scholar. So one of my first research projects was actually learning about the implicit model. And really the focus of implicit is that it is based in a family medicine space or practice in which individuals may be or postpartum individuals may be bringing their infant for care, right, for well child visits. But at the same time, there are considerable health needs for that postpartum person. So really coupling and using that space as a way for screening, as a way for connecting them with important services post-delivery. And so it was developed through a national network, and we're actually, our local region is actually one of the leaders in that network. Dr. Stacy Bartlett serves as one of the PIs of the Implicit Network. And part of the focus is developing and implementing models of care focused on improving maternal and child health, providing the interconceptional care, which I mentioned, which is screening for behavioral outcomes as well and mental health supports, but then also thinking about the fourth trimester. So going beyond, in many cases, even the first 2 to 4 weeks postpartum, beyond even the 6 to 8 weeks postpartum and what supports are necessary. And so the ICC study specifically for Embrace is really leveraging that structure, leveraging the existing healthcare systems model that is in place here locally in Pittsburgh, but also across the region. So if you were to just search implicit, you would actually see a number of implicit specific models that are being implemented across the East Coast. And so our study in particular is looking at a sequential mixed methods approach. So once again, using some of the quantitative medical data to understand outcomes of those who've actually engaged in the model so far. And then also our qualitative analysis, which is really hearing from the practitioners who are implementing a lot of this model. So that has included interviews with physicians, residents, and clinical staff. As well as ongoing data collection with postpartum individuals who've experienced this their model. And then this data will be used to inform and co-develop a new postpartum care model, which is really integrating the tenets of reproductive justice and community-informed care. One of the, I would say, outcomes as well of this work is that our team within the implicit research study in collaboration with our training component team, have engaged in a number of trainings around reproductive justice, right? So there are core elements of reproductive justice that we may be familiar with, right? That even if you hadn't seen the tenets in the model that I shared earlier, you say, oh, I'm familiar with that. That makes sense. Or yes, I think about that in this way. I didn't necessarily articulate it as RJ. And so that really helps to kind of level and provide some capacity around what does this mean, but then how do you implement it? What does it look like in practice to actually implement reproductive justice as a praxis? And then one of the other core elements of the 4TM ICC study is community partner integration. And so this, as I mentioned, has included key community partners, community health advocates who've been integrated into the project planning and execution, as well as upcoming plans for data analysis, piloting our work, and then also building a community coalition for the cash transfer work. And so I mentioned our third aim includes a cash transfer, unconditional cash transfer pilot. And that particular work is being led by Dr. Tamar Krishnamurti. And really the thought is that we are in a space of talking about longstanding inequities in maternal health, right? Severe maternal mortality and morbidity. But we also have to have the conversation, and in this current environment and climate, what policies do we have in place and how are those being actualized? And one in particular has been family leave. There are state level actions around family leave, state level actions around supports for individuals. And what we know in prior work is that many individuals are in a space where they cannot take the leave that is necessary to care for themselves and their infants, their newborns, are moving back into workspaces in many ways that can be toxic and not supportive of their health and well-being, right? And so one of the core approaches of our work is to understand, like, what does the literature say? What are we learning here in the United States, but also in other countries that have implemented a lot of these policies that we believe are really important and critical for maternal health and well-being. We've also been in the process of interviewing experts who've actually implemented unconditional cash transfer programs. Some of you may be familiar with the program out of, I want to say, Michigan and Ohio, is a pediatrician, right, that started the RX, I think it's called the RX initiative, which is very similar to what I'm sharing here. And really the thought is, as a pediatrician, I can write a prescription for medicine, but I can also write a prescription for what we consider social determinants of health. And one of those is, how do we provide direct cash and resources to people who need them, right? And to actually address their core needs. And so our pilot really is to design and pilot this within a small subsample of our population, assess the feasibility, acceptability, and use of funds. And then also we've collaborated with the health department. As I mentioned, we've done a local version of the PRAMS, Pregnancy Risk Assessment Monitoring System survey. And we've asked the health department, can we include some questions around the cash transfer? Can we get a little bit of feedback from pregnant folks in the region? And as you can imagine, 81%, what we know so far from the data collected, 81% have responded that they agree or strongly agree that they would be interested in a cash transfer initiative or pilot. And so this, once again, reflects a paid parental leave. So not only family leave, right, but paid family leave, paid parental leave for 8 weeks. And this equates to about $4,500 over the 8-week period. And what we'd be doing is tracking the spending, understanding kind of spending behaviors and what goes into that, and then other health outcomes such as healthcare utilization, mental health outcomes, as well as feasibility and acceptability. All right, so I have about 5 minutes, and I'm just going to go quickly through some other core elements of our center, just so I can make sure that I acknowledge and uplift many of the individuals leading this work in collaboration. And so once again, I mentioned that we have this multi-level framework, and our core health systems level intervention was funded through the U54 NIH opportunity. But we were recently awarded a supplement to do a pilot of our community-related intervention. And that's actually led by Dr. Marquise Hawkins at Pitt and Demia Tyler, who is now the COO of Healthy Start, along with a number of colleagues. And really the focus is to identify sleep health needs, barriers, and determinants with implementation with community health workers, right? And so this is informing a sleep health intervention, really looking at the links between sleep, stress, and maternal health outcomes, using human-centered design to inform and develop a tailored intervention. Really quickly, we also have our training component. Once again, this is building capacity. And I wanted to highlight this because many of you in the room today may be interested in some of the activities and opportunities that we are offering through our training component. And that includes mentorship and support across the continuum, right? So graduate students, residents, early career faculty, but also capacity building around reproductive justice. We've done capacity building around data justice and community engaged work. Here are some of our training component team members who are really critical to this work. We've also been leading a seminar series. So actually later today, if you are interested, our co-leads for the ICC research study that I mentioned will be presenting and providing a little bit more detail and nuance to what is actually happening with that study. So for those in the room who are interested, let me know. I'll share that information with you. We also have an internship program. Once again, we've done the reproductive justice trainings, and that's been in collaboration with New Voices for Reproductive Justice, one of the leading RJ organizations in the region in Pennsylvania and Ohio. We have the Embrace Book Club, and then we also have a community engaged research pilot. So I wanted to uplift that because many of you in the audience may be interested in that. Look out for an announcement coming probably tomorrow. That really details a pilot program, research program that we have for investigators in collaboration with community investigators on core questions in reproductive health. All right, I'm going to just skip through. This is just a little bit of an illustration of our key seminar series and leaders, our one-on-one trainings that we've done, our key collaborators for our RJ trainings, our community engaged pilot, which I mentioned, so please look out for that because I'd love to see some applications from many of you in this room who are engaged in community-based research and praxis. Our wonderful trainees and students. Our community component, which is central, right? I mentioned community engaged praxis, and so What we are doing now, I say we're kind of building the ship as we're steering it. There's so many ways in which we can think about engaging community and implementing that in our work. And so that sometimes takes pivots. Sometimes that takes, we're going to try this method or we're going to move forward in this way, but maybe we need to think about other ways to do that as well. And so it is a collaborative, iterative process in terms of working with leaders in this work who are in many of the nonprofit agencies, but also governmental agencies. I shared a little bit about some of the leadership here, and that includes Jada, Onome, and Dr. Hill, along with a number of other colleagues from Healthy Start. And I'm going to go through this quickly. One of the things that we also are leading is a reproductive research advisory board, and I wanted to uplift that as well because we plan to kick that off within the next month. And so many of you in this room who may be conducting research in this space of reproductive health may be interested in receiving feedback and support from community partners around that work. And so look out for the RRAB as well. It's similar to maybe a community research advisory board, but the way in which this operates is that any researcher can come to the space and say, hey, I have a number of questions that I'd like to put before perhaps an outside community voice to receive feedback and support. Our data justice working group, I wanted to mention as well, because they've been really instrumental in moving us forward and thinking about data justice from the perspective of data governance and transparency. Who has access to the data, how it's used, why it's used, and what are the implications of that data? This is our core team. Many of you are probably familiar with Dr. Liz Miller, who is a collaborator from the Department of Pediatrics on this core team. And some of the key highlights that I'll mention is, as I shared a little bit earlier, is the PRAM survey, really working closely with the Allegheny County Health Department. We actually partially help to partially fund our local Allegheny PRAMs, which we plan to continue to do. But we've also been engaged with data transparency activities through the Allegheny County Allegheny Health Network. So also working with other health networks and thinking about data, thinking about how it's used and what are the implications of that data. And then finally, we've also been working with a larger strategic group behind the birth plan. So that birth plan that I showed at the very beginning includes over 50 organizations. And so working closely with them to understand what are their needs, how are they engaging with community now, especially in this current environment, and what supports could help move their work forward. All right, and then finally, our communications and dissemination. And what we say is the work that we do should live in multiple spaces, right? So we should be presenting our work in audiences, publishing in peer-reviewed publications, but it needs to go beyond that as well. And so working with a team of partners, and one of the key partners that we work with is an artist in residence. So one of the things that I'm really excited about is how do we use art? How do we use the creative space to talk about our research and disseminate and connect with community? Right? We don't necessarily just come and present our data in community spaces. That's important. But then how do we connect with them from a humanistic standpoint? All right. And these are some of the other activities related to dissemination. Podcast and development. Have worked with film makers and leaders, our annual symposium with community partners. We've done a belly casting recently for pregnant individuals, and then also working closely with our state reps who are leading work in policy around maternal health. And finally, our policy working group. Again, our policy study was not funded, but it was really foundational to our argument around ensuring that structural and policy level interventions are at the center of the work that we do. All right, and so this is just a few pictures to illustrate, once again, the work that is happening and being done. I hope that you all consider connecting with us, and you can do so by scanning this QR code, visiting our website. Please join our listserv, our newsletter, so that you can receive information about some of the opportunities that I mentioned, and I'm open for questions. Thank you.